Hello everyone. Welcome back to our OCT series public lecture. Today, let's take a look at aspects related to measuring OCT images. We will continue the content of OCT image interpretation. In the previous lecture, we mentioned that some patients have plaque rupture. Fibrous cap disruption leads to plaque rupture. The lipid core and cholesterol crystals inside are completely released. At this point, a cavity forms, followed by the development of a hematoma. For this hematoma, we can estimate its size by measuring its area. In some cases with large hematomas, or patients with dissection, excessive pressure during angiography may lead to severe hematoma. Therefore, we could use OCT for such measurements. However, we need to be vigilant about one point. During OCT examination, a large volume of contrast agent must be injected, and sometimes the injection pressure may be relatively high. If a spiral dissection is already detected during the test injection, puff test, it is best to discontinue the subsequent OCT examinations, because this procedure may cause the dissection to enlarge significantly, which can become difficult to manage. In such situations, we may need to gently deploy a stent at the lesion site to cover the distal intimal tear first, so that it can reduce the spread of hematoma and ensure the safety of the postoperative procedure. First, we must ensure the postoperative procedural safety. The last section is about stent-related measurements. For stent-related measurements, the main focus is on the issue of stent apposition. We also mentioned this last time. There are two different judgment criteria for stent apposition. One is that if the distance between the stent strut and the vascular intima exceeds 200 micrometers, it definitely indicates poor stent apposition. As we can see in this OCT image, the imaging of the intima and the stent struts are very clear. When we measure this distance between stent struts and the intima, we can see that it is close to 350 micrometers, which clearly indicates inadequate stent apposition. In addition to this, we can even identify inadequate stent apposition with the naked eye. The measurement only serves to provide relatively accurate quantitative data. In fact, the target vessel diameter here is actually 3.0 millimeters, and a 3.0 millimeters stent was implanted. However, our actual measurement shows that the expanded diameter of the stent is only around 2.75 to 2.8 millimeters. This further confirms from another perspective that the stent has insufficient expansion and poor apposition. On the right is an Ivers image, which can also be used to assess post-PCI stent status, because we can measure it through diameter and area expansion ratio. However, its imaging quality is inferior to that of OCT. That's all for today.